Today, we're diving deep into the really intricate systems that control our blood pressure and our fluid balance. In this explainer, we'll first build up the core physiology that keeps our bodies in equilibrium. And then, we'll break down the pharmacology of the key drugs we use to intervene when that balance is lost. So here's our game plan. We're going to start by building a really solid foundation in the physiology of vascular tone. From there, we'll dig into the super powerful ROS pathway and other vasoactive therapies. Then we'll shift our focus over to the kidney. First, getting a handle on its role in fluid balance, and then looking at how different diuretics work and how we actually use them in the clinic. All right, let's jump right into section 1. Before we can even begin to talk about drugs that change blood pressure, we absolutely have to understand the fundamental concept of vascular tone and the body's own natural ways of controlling it. So what exactly is vascular tone? At its heart, the definition is pretty simple. It's just the degree of contraction. Think of it as how squeezed the smooth muscle cells are inside the walls of our blood vessels. This constant, partial contraction is what keeps our blood pressure up and makes sure blood flows steadily.
Now this slide shows the two opposing forces that are constantly at play determining our vascular tone. It's a nonstop balancing act. Let's look at the left side first, the pathway for contraction. The key player here, the star of the show, is calcium. When these L-type voltage-gated channels open up, calcium ions just flood into the cell. This calcium then grabs onto a protein called calmodulin, and that complex flips a switch on another enzyme, myosin light chain kinase, or MLCK. The job of MLCK is to slap a phosphate group onto the myosin light chain. This allows it to form cross bridges with actin, and bang, the muscle cell contracts. Now over on the right, we've got the relaxation pathway. Here, nitric oxide, or NO, gets things going by stimulating an enzyme called guanylyl cyclase. This converts GTP into cyclic GMP, or cGMP. Then cGMP activates myosin light chain phosphatase, which does the exact opposite of MLCK. It rips that phosphate group off of myosin, preventing cross bridges from forming and causing the muscle to relax. So you see, it's contraction versus relaxation, all governed by these very precise signals inside the cell.
So this delicate balance doesn't just happen by accident. It's tightly controlled by a whole bunch of signals. We can really group them into 3 main categories. First, you've got mediators from the endothelium. That's the inner lining of the blood vessel itself. Things like the vasodilator nitric oxide and the incredibly potent vasoconstrictor endothelin. Second, there's the sympathetic nervous system, which releases norepinephrine to act on alpha receptors, causing vasoconstriction. And third, you have a whole range of neurohormonal mediators just circulating in the blood, like epinephrine, the powerful angiotensin II, which we're going to talk a lot more about, vasopressin, and the natriuretic peptides, which actually help things relax. Okay, let's move on to one of the most critical and pharmacologically important regulatory systems in the entire body, the renin-angiotensin-aldosterone system, or as everyone calls it, RAS. This diagram is fantastic because it shows us the entire ROS cascade. Let's just walk through it. It all starts in the liver, which is just constantly churning out a protein called angiotensinogen. Then, when the kidney senses a problem, say low blood pressure, it releases an enzyme called renin. Renin's job is to cut angiotensinogen, turning it into angiotensin I. As angiotensin I circulates through the lungs, an enzyme on the surface of the lungs' blood vessels, called angiotensin-converting enzyme, or ACE, converts it into the superactive angiotensin II. Now, angiotensin II is the real powerhouse of this system. It does a few things. It causes powerful vasoconstriction in the arterioles, directly cranking up blood pressure. It also hits the adrenal gland to stimulate aldosterone secretion, which tells the kidney to hold on to sodium and water, increasing blood volume. And finally, it stimulates ADH secretion from the pituitary, which promotes even more water retention. The end result? A huge increase in both vascular tone and fluid volume. So what actually kicks this whole thing off? Well, the kidney is the primary sensor. It releases renin when it detects one of 3 main triggers. First, direct sympathetic stimulation of beta-1 adrenoceptors on the kidney cells. Second, renal artery hypotension. That just means the kidney itself senses a drop in its own blood pressure or blood flow. And third, there are these specialized cells in the distal tubules that sense a decrease in sodium delivery, and they interpret that as a sign of low overall volume in the body. Now here's where it gets really interesting. Angiotensin II doesn't just act randomly. It works through specific receptors, and as you can see here, they have opposite jobs. The AT1 receptor is basically the bad guy. It's responsible for all the classic RAS effects that contribute to disease: vasoconstriction, fibrosis, inflammation, oxidative stress, you name it. But there's another side to the story. The AT2 receptor and the MAS receptor actually mediate protective effects. They cause vasodilation, and they have anti-fibrotic and anti-inflammatory actions. So naturally, most of our drugs are designed to target that harmful AT1 pathway. Okay, so with that whole pathway understood, we can now see exactly where our drugs step in to interrupt the process. This diagram lays it out perfectly. We can use renin inhibitors to block the very first step. We can use ACE inhibitors to stop the conversion of angiotensin 1 to angiotensin 2. Or we can use angiotensin receptor blockers, or ARBs, to directly stop angiotensin 2 from binding to its harmful AT1 receptor. And hey, notice that bradykinin pathway on the right? ACE doesn't just make angiotensin 2, it's also responsible for breaking down bradykinin, which is a vasodilator. This little detail is going to become super important when we talk about the side effects of ACE inhibitors. First up, let's talk about the workhorses, the ACE inhibitors. These are used all the time for hypertension, heart failure, and after heart attacks. As the table shows, they come in a few different flavors. Captopril is an active drug itself, but it has a really short half-life of only 2 hours. Enalapril and ramipril are what we call prodrugs, meaning they have to be converted to their active forms in the body, but they last much longer, around 11 hours. Then there's lisinopril, which is unique because it's an active drug that's just excreted unchanged by the kidneys and has a nice long half-life of 12 hours. Now, understanding the adverse effects of ACE inhibitors is absolutely crucial. First, remember how they block the breakdown of bradykinin? Well, that buildup can cause a really persistent, annoying dry cough and sometimes taste disturbances. They can also cause a big drop in blood pressure, especially with the very first dose. In patients with bilateral renal artery stenosis, they can cause reversible kidney impairment. That's because those patients are relying on angiotensin 2 to constrict the exit vessel of their kidney filter to keep it working. These drugs can also cause hyperkalemia or hypotassium, especially in people with kidney problems. And finally, a huge safety point: they are teratogenic and must never, ever be used during pregnancy.
This brings us perfectly to the next class, the angiotensin 2 receptor antagonists, or ARBs, like losartan and candesartan. These drugs offer a really key advantage. They work by directly blocking the AT1 receptor, so they don't mess with bradykinin levels at all. This means they give you very similar clinical benefits for hypertension and heart failure as the ACE inhibitors, but, and this is the big one, without causing that characteristic dry cough. This makes them a fantastic alternative for patients who just can't tolerate an ACE inhibitor. Their other potential side effects, like hypotension or hyperkalemia, are pretty similar.
So that's the ROS system covered. Now let's broaden our focus a bit. Because beyond ROS, there are several other really important pathways and drug targets for changing vascular tone. Let's start with a classic: the nitrates, or nitric oxide donors. Drugs like glyceryl trinitrate, or GTN, work by releasing nitric oxide directly in the body. And as we saw way back at the beginning, NO is a powerful vasodilator. At the doses we typically use, nitrates have a preference for dilating large veins. This venous dilation reduces the amount of blood coming back to the heart, what we call preload, which decreases the heart's workload and its demand for oxygen, making them excellent for treating angina. But there's a pretty significant clinical problem with nitrates, and that's tolerance. If you're exposed to them continuously, their effect just gets weaker over time. We don't know the exact mechanism for sure, but this slide lays out the leading theories. It could be that the body loses its ability to convert the drug to active NO, or it runs out of necessary cofactors. Maybe the target enzyme itself gets inactivated, or the body just fights back with its own vasoconstrictors. It could even be due to oxidative stress or an expansion of plasma volume. This whole issue of tolerance is exactly why we recommend a nitrate-free period, usually overnight, for patients on long-acting versions. Next up, the calcium channel blockers, or CCBs. These drugs work by blocking those L-type calcium channels we talked about, preventing the calcium influx that makes smooth muscle contract. But here's the thing: not all CCBs are the same. As this table shows, they fall into 3 classes with different preferences. The dihydropyridines, like nifedipine and amlodipine, are much more selective for vascular smooth muscle, which makes them great vasodilators for treating hypertension. The phenylalkylamines, like verapamil, are more selective for the heart itself, where they slow the heart rate and reduce how hard it squeezes, which is useful for arrhythmias. And then the benzothiazepines, like diltiazem, are kind of in the middle, affecting both the heart and the blood vessels.
This slide just gives a quick summary of several other important vasoactive drug classes. So endothelin is the body's most potent natural vasoconstrictor, and drugs like bosentan block its receptor, which is especially useful for treating pulmonary hypertension. Phosphodiesterase 5, or PDE5, is an enzyme that breaks down cGMP. So inhibitors like sildenafil stop that breakdown, which prolongs cGMP's vasodilatory effect. Potassium channel openers, like minoxidil, cause hyperpolarization of the smooth muscle cell membrane, which then closes calcium channels and causes profound relaxation. And finally, there's an older drug, hydralazine, which we think works by messing with how calcium is released from the cell's internal stores.
All right, we are now shifting gears in a big way. We're moving away from the arteries and vascular tone and focusing on the kidneys and volume regulation. To really understand how diuretics work, we first need a crystal clear picture of how the kidneys normally handle all that fluid and electrolytes. This diagram here is going to be our essential map for the next couple of sections. It shows a simplified nephron, which is the functional unit of the kidney. We can follow the journey of the filtrate, starting at the glomerulus, moving through the proximal convoluted tubule, down and then up the loop of Henle, including that important thick ascending limb, then through the distal convoluted tubule, and finally into the collecting duct. At each step, different amounts of sodium, ions, and water get pulled back into the body. And those green labels? They show us exactly where the major classes of diuretics are going to do their work. Okay, let's move on and see exactly how these drugs, which people often call water pills, really work. You see, they don't act on water directly. Instead, they work by targeting those specific ion transporters all along our nephron map to block sodium from being reabsorbed. And the number one rule in the kidney is, where sodium goes, water follows. This table gives us a great summary of the main players. First, we have the loop diuretics. These are by far the most powerful diuretics we have. They act in the thick ascending limb, or tail, where they block the sodium-potassium 2-chloride cotransporter. Now, because this part of the nephron is responsible for reabsorbing about 25% of all filtered sodium, blocking it leads to a massive increase in sodium and water being flushed out. Next are the thiazide diuretics. They work further downstream in the distal convoluted tubule, or DCT, where they block the sodium chloride cotransporter. This site only handles about 5% of sodium reabsorption, so their effect is much more moderate. Finally, we have the potassium-sparing diuretics. They act in the very last segment, the collecting duct, blocking either sodium channels or the aldosterone receptor, and they have the mildest effect, blocking only about 1 to 2% of sodium reabsorption. Okay, so let's connect these mechanisms to the clinic. It's so important to understand not just how these drugs work, but why we choose a specific one for a particular condition, and what critical side effects we absolutely have to watch out for. Now, here is a really crucial point to understand, especially for side effects. It's the completely opposite effects that loop and thiazide diuretics have on your calcium levels. Loop diuretics like furosemide act in the thick ascending limb, where they disrupt the electrical gradient that normally drives the reabsorption of calcium. The result is you lose more calcium in the urine, which can lead to hypocalcemia. In fact, we can actually use this effect to treat people with dangerously high calcium levels. In complete contrast, thiazide diuretics like hydrochlorothiazide actually inhibit calcium secretion in the distal convoluted tubule, which causes the body to hold on to calcium, and that can lead to hypercalcemia. One thing they both have in common, though, is the risk of causing hypokalemia or low potassium. That's because the increased sodium load that gets delivered to the collecting duct drives more potassium out into the urine. So we've covered the individual pathways for tone and volume in a ton of detail. We've looked at ROS inhibitors, vasodilators, and all sorts of diuretics. But, in the real world, patients are often on multiple medications at the same time. So the final question to really think about is, how do all these drugs and the body's own attempts to compensate all interact with each other? How does this polypharmacy impact the net regulation of a patient's vascular tone and volume? That right there is the central challenge of clinical pharmacology.